Inhaled corticosteroids are medications that improve breathing by decreasing lung inflammation. They are primarily used in clients with persistent asthma, meaning those who have asthmatic symptoms more than 2 days per week. Asthma is characterized by chronic inflammation in the lungs, as well as asthma exacerbations or attacks, where certain triggers, such as viruses, allergens, stress, aspirin or other NSAIDs, and exercise lead to reversible bronchial smooth muscle spasms and mucus production, both of which make it hard to breathe. As a result, clients experience symptoms like dyspnea, wheezing, chest tightness, and coughing. Inhaled corticosteroids help decrease the frequency of symptoms and prevent exacerbations. Inhaled corticosteroids can also be used in clients with chronic obstructive lung disease, or COPD, to prevent exacerbation and slow the progression of the disease. Now, commonly used inhaled corticosteroids include fluticasone, beclomethasone, budesonide, and mometasone. These medications are typically used as maintenance therapy to help control the underlying lung inflammation and are often combined with inhaled bronchodilators, such as long-acting beta-2 agonists like salmeterol, which provide immediate relief of symptoms by inducing airway smooth muscle relaxation. Now, once in the lungs, inhaled corticosteroids enter the respiratory epithelial cells and suppress the expression of certain genes that code for inflammatory proteins. This leads to decreased movement of inflammatory and immune cells into the bronchi and lungs, as well as decreased production and release of inflammatory mediators like histamine and leukotrienes. As a result, there's reduced airway inflammation and edema, as well as decreased mucus production, which ultimately leads to airway dilation and improved airflow. Because they work on the gene level, inhaled corticosteroids may need days or even weeks to demonstrate effectiveness. That's why they are only used to prevent exacerbations of asthma and COPD and should not be used to treat acute episodes. Since inhaled corticosteroids control the underlying lung inflammation, clients will need to take them daily, even when they feel well. Now, inhaled corticosteroids mainly cause localized side effects that result from the deposits left in the mouth or larynx as they travel down into the lungs. Inhaled corticosteroids weaken the immune defense mechanisms in the mouth, which can lead to infection by the fungus Candida albicans and results in oropharyngeal and esophageal thrush. Prolonged use of corticosteroids can also result in immunosuppression, which may cause or prolong respiratory tract infections like pneumonia. Other side effects of inhaled corticosteroids include a sore throat, hoarseness, and cough. Less commonly, inhaled corticosteroids are associated with other side effects, especially when used in high doses and for a long duration. These include hypercortisolism and suppression of the hypothalamic pituitary adrenal axis. As a result, if the client abruptly stops using corticosteroids, the adrenal glands may be unable to produce enough cortisol. Additional side effects of inhaled corticosteroids include increased appetite and weight gain, increased risk of fractures, osteoporosis, and decreased bone growth rate in children. Now, in general, inhaled corticosteroids are considered to be safe and effective medications. However, they are contraindicated in clients who have an active respiratory tract infection, like pneumonia or tuberculosis, and they should be used with caution in those with cataracts or glaucoma, since corticosteroids can make these conditions worse. Inhaled corticosteroids are also contraindicated in clients with hypersensitivity to the medication, as well as those with severe allergy to milk proteins or lactose, since the inhaled preparation may contain these ingredients. Now, before administering an inhaled corticosteroid, ensure your client understands why the medication is prescribed, the correct method of administration, and common side effects to watch for. Be sure your client understands that inhaled corticosteroids are used only as a preventative therapy, so the medication should be taken on a regular schedule and should never be used to stop an acute attack. Stress the importance of taking their medication every day, even if they're feeling well. If your client is also prescribed a short-acting beta-agonist bronchodilator, remind them to take the bronchodilator 5 minutes before taking the inhaled corticosteroid, because it will increase the amount of corticosteroid delivered to the lungs. Next, teach your client how to administer their medication. When using a metered dose inhaler, or MDI, demonstrate how to use a spacer. and explained that it promotes maximal delivery of the medication to the lungs while reducing the risk of oropharyngeal and esophageal thrush. Demonstrate how to shake the MDI canister and attach the spacer. Then show them how to exhale all the air out of their lungs, put the spacer mouthpiece in their mouth, making a tight seal, and then press down on the MDI. At this point, explain that the medication is now trapped in the spacer. So next, they should inhale slowly and deeply, hold their breath for 5 to 10 seconds, and then fully exhale. If the client needs to take more than one puff of the inhaled corticosteroid at one time, instruct them to wait 1 minute before administering the second puff. Afterwards, instruct them to gargle and rinse their mouth to decrease the risk of oropharyngeal and esophageal thrush. After the demonstration, ask your client to provide a return demonstration so you're sure they feel comfortable self-administering their medication. Now, because the long-term use of inhaled corticosteroids can increase the risk of osteoporosis, advise your client to promote bone health by routinely consuming a diet high in vitamin D and calcium, and to perform weight-bearing exercises. Remind your client that use of inhaled corticosteroids can also increase the risk of respiratory infections, so advise them to avoid contact with cigarette smoke and those with respiratory infections. They should also receive an annual influenza vaccination. Remind them to report symptoms such as cough, fever, sore throat, or shortness of breath. As you care for your client, your ongoing evaluation includes routine monitoring of their peak expiratory flow, or PEF, symptom frequency and intensity, how often symptoms wake them up at night, activity tolerance, and how often a short-acting bronchodilator is needed. If your client is prescribed a high dose of inhaled corticosteroid, monitor them for signs of hypercortisolism, such as elevated glucose, increased weight, and accumulation of fat around the abdomen and upper back. Report any concerning signs or symptoms to the healthcare provider. All right, as a quick recap, inhaled corticosteroids are medications that reduce inflammation in the lungs and are used for long-term maintenance of asthma or COPD symptoms. They can be administered using an MDI, DPI, or a nebulizer. Inhaled corticosteroids are generally safe to use. However, there are a few contraindications, including an active respiratory tract infection or hypersensitivity to lactose or milk proteins. They should be used with caution in clients with cataracts or glaucoma. Potential side effects include oropharyngeal and esophageal thrush, osteoporosis, and decreased bone growth in children. Nursing considerations when caring for a client prescribed an inhaled corticosteroid includes education on correct self-administration, reducing the risk of side effects, and evaluating the therapeutic effect of medication administration.